Understanding bilirubin terminology prevents confusion when interpreting laboratory results and planning treatment. The various terms describe the same molecule at different stages of metabolism, each with distinct clinical implications. Unconjugated bilirubin, also called indirect bilirubin, represents the initial breakdown product of hemoglobin. When red cells die after their 120-day lifespan, or earlier in hemolytic conditions, hemoglobin releases heme. The reticuloendothelial system converts heme to biliverdin, then to unconjugated bilirubin. This fat-soluble molecule requires albumin binding for transport through blood. Think of unconjugated bilirubin as the raw product. It cannot dissolve in water, making excretion impossible until the liver modifies it. The diagram illustrates how unconjugated bilirubin travels to hepatocytes, where the enzyme UGT1A1 performs conjugation. This process attaches glucuronic acid molecules, transforming fat-soluble bilirubin into water-soluble conjugated bilirubin. We call this conjugated form direct bilirubin because it reacts directly with laboratory reagents without additional processing. Here's why terminology matters clinically. Elevated unconjugated bilirubin suggests either increased production from hemolysis or decreased conjugation from liver immaturity. Elevated conjugated bilirubin indicates the liver successfully conjugated bilirubin, but cannot excrete it. Think biliary obstruction or hepatocellular damage. The ratio guides our differential diagnosis. Mixed hyperbilirubinemia, with elevations of both forms, suggests liver disease affecting multiple steps. Neonates commonly present with predominantly unconjugated hyperbilirubinemia due to immature UGT1A1 activity, while conjugated hyperbilirubinemia always indicates pathology requiring investigation. Bilirubin metabolism represents an elegant system for eliminating potentially toxic heme products while creating useful byproducts. Following this pathway step by step reveals why disruptions at different points create distinct clinical syndromes. The process begins when senescent red blood cells get phagocytosed by reticuloendothelial macrophages, primarily in the spleen. These cells contain heme oxygenase, which opens the heme ring to form biliverdin. Biliverdin reductase immediately converts this green pigment to unconjugated bilirubin. This yellow lipophilic molecule cannot travel freely in plasma. It requires tight albumin binding for transport. The liver performs the crucial transformation. Hepatocytes take up albumin-bound bilirubin through specific membrane transporters. Inside hepatocytes, the enzyme UDP-glucuronylyl transferase 1A1 catalyzes conjugation with glucuronic acid. This conjugation creates water-soluble bilirubin diglucuronide, enabling excretion. Neonates have limited UGT1A1 activity at birth, explaining physiologic jaundice. Genetic UGT1A1 deficiency causes Crigler-Najjar syndrome. Conjugated bilirubin gets actively secreted into bile canaliculi, flowing through the biliary tree into the intestine. Here, bacterial beta-glucuronidases deconjugate some bilirubin, while other bacteria reduce it to colorless urobilinogen. Most urobilinogen undergoes further reduction to brown stercobilin, giving stool its characteristic color. About 20% of urobilinogen gets reabsorbed, the enterohepatic circulation. The liver re-excretes most reabsorbed urobilinogen, but small amounts reach systemic circulation and undergo renal excretion as urobilin, contributing to urine's yellow color. This intricate pathway explains clinical findings. Pale stools suggest biliary obstruction preventing bilirubin excretion. Dark urine with conjugated hyperbilirubinemia indicates water-soluble bilirubin reaching kidneys. Understanding each step enables targeted evaluation when hyperbilirubinemia develops. Preterm infants face a perfect storm of factors that dramatically increase bilirubin production compared to their term counterparts. The shortened red blood cell lifespan drives excess production. While term infant red cells survive 90 days and adult cells 120 days, preterm red cells last merely 60 to 70 days. This accelerated destruction means a 28-week infant produces nearly twice the bilirubin load of a term baby. Every circulating red cell represents a future bilirubin molecule, and preterms cycle through these cells at breathtaking speed. Polycythemia compounds the problem. Chronic intrauterine hypoxia stimulates erythropoietin, creating hematocrits exceeding 65%. More red cells mean more eventual bilirubin when those cells die. Additionally, delayed cord clamping, while beneficial for iron stores, increases the red cell mass requiring breakdown. Increased heme catabolism extends beyond erythrocytes. Preterm infants have elevated tissue heme from resolving cephalohematomas, extensive bruising from difficult deliveries, and internal hemorrhages. Each gram of blood yields 34 milligrams of bilirubin. A small intraventricular hemorrhage adds significant bilirubin load. The bruising deserves special attention. Vacuum-assisted deliveries create extensive scalp bruising. Breech extractions leave bruised buttocks and legs. Each bruise represents millions of extravasated red cells undergoing breakdown. Unlike contained blood in vessels, bruised blood cannot be removed by phlebotomy, guaranteeing its complete conversion to bilirubin over the following days. Preterm infants struggle with bilirubin elimination through multiple interconnected mechanisms, creating the elimination bottleneck that allows bilirubin to accumulate to dangerous levels even with normal production rates. The fundamental problem lies in hepatic immaturity. UDP glucuronose transferase 1A1, the enzyme responsible for conjugating bilirubin, operates at merely 1% of adult activity in preterm infants. Picture trying to drain a bathtub through a straw. The backup is inevitable. This enzymatic immaturity persists for weeks, improving gradually with postmenstrual age rather than postnatal age. Impaired hepatic uptake compounds the conjugation problem. Even when unconjugated bilirubin reaches the liver, immature hepatocytes cannot efficiently extract it from circulation. The transport proteins responsible for moving bilirubin from sinusoidal blood into hepatocytes function poorly. This creates a traffic jam, bilirubin waiting to enter hepatocytes that already cannot process what they contain. Hypoalbuminemia critically impacts bilirubin transport. Preterm infants typically maintain albumin levels of 2 to 3 grams per deciliter versus 3 to 4 in term infants. Since each albumin molecule carries one bilirubin molecule, reduced albumin means reduced transport capacity. Free, unbound bilirubin can then cross the blood-brain barrier, causing kernicterus. Delayed stooling patterns seal their fate. While term infants pass meconium within hours, preterm infants often require days. Meconium contains significant bilirubin, approximately 1 milligram per gram. Retained meconium undergoes deconjugation by intestinal beta-glucuronidase, allowing reabsorption. Every day of retained meconium adds to the circulating bilirubin pool. This explains why glycerin suppositories and early feeding strategies significantly reduce peak bilirubin levels. The enterohepatic circulation of bilirubin creates a recycling system that frustrates our attempts to clear jaundice, particularly in preterm infants where every step functions suboptimally. This pathway explains why bilirubin levels rebound after stopping phototherapy. The cycle begins when conjugated bilirubin reaches the intestinal lumen through bile. In adults, bacterial flora quickly metabolize this to urobilinogen and stercobilin for excretion. However, preterm infants have minimal bacterial colonization, especially those receiving antibiotics. Without bacterial metabolism, conjugated bilirubin persists in the intestinal lumen. Beta-glucuronidase, abundant in neonatal intestinal brush borders, deconjugates bilirubin back to its unconjugated lipid-soluble form. This enzyme shows particularly high activity in preterm infants. The diagram illustrates how this unconjugated bilirubin readily crosses intestinal epithelium, re-entering portal circulation. From there, it returns to the liver, requiring reconjugation and re-excretion. Intestinal motility dramatically impacts this recycling. Preterm infants with delayed gastric emptying and prolonged intestinal transit times allow more opportunity for deconjugation and reabsorption. Each hour bilirubin spends in the intestine increases recycling. Formula-fed infants show less enterohepatic circulation than breastfed infants because formula promotes faster transit and earlier bacterial colonization. The clinical implications guide management. Early feeding stimulates gut motility, reducing transit time. Phototherapy converts bilirubin to water-soluble photoisomers that resist enterohepatic circulation. However, when phototherapy stops, the remaining unconjugated bilirubin resumes recycling, explaining rebound hyperbilirubinemia. Understanding this mechanism helps predict which infants need prolonged monitoring after phototherapy discontinuation. Those with delayed stooling, poor feeding, or extreme prematurity face the highest rebound risk. Distinguishing physiologic from pathologic jaundice represents one of the most critical skills in newborn care. This differentiation determines whether we observe safely or intervene urgently to prevent permanent neurologic damage. Physiologic jaundice follows predictable patterns that reflect normal neonatal adaptation. Onset occurs after 24 hours of life. This timing is crucial. Any visible jaundice in the first 24 hours is pathologic until proven otherwise. Physiologic jaundice peaks between days 3 to 5 in term infants, slightly later days 5 to 7 in preterms. The bilirubin rise stays modest, under 5 mg per deciliter daily, with peaks below 12 to 14 mg per deciliter in term infants. The mechanism involves normal developmental immaturity. Limited UGT1A1 enzyme activity reduces conjugation capacity, while increased red cell breakdown from shorter lifespans generates more bilirubin. This combination creates temporary accumulation that resolves as enzyme systems mature. Resolution occurs by 1 week in term infants, 2 weeks in preterms. Persistence beyond these timeframes warrants investigation. Pathologic jaundice breaks these rules and threatens neurotoxicity. Appearance within 24 hours suggests hemolysis. Think ABO incompatibility, G6PD deficiency, or sepsis. Rapid rises exceeding 5 mg per deciliter per day indicate overwhelming production or severely impaired elimination. Any conjugated bilirubin elevation above 2 mg per deciliter, or 20% of total, signals hepatobiliary disease requiring immediate evaluation. The key distinction lies in trajectory and timing. Physiologic jaundice follows gentle curves with predictable peaks and resolution. Pathologic jaundice shows steep rises, early onset, prolonged duration, or conjugated components. When uncertain, err toward investigation. A simple fractionated bilirubin can prevent kernicterus. Understanding hyperbilirubinemia risk factors enables targeted screening and early intervention before bilirubin reaches dangerous levels. These factors often overlap, creating multiplicative rather than additive risk. Jaundice within 24 hours tops our concern list because it always indicates pathology. The differential includes immune-mediated hemolysis from ABO or Rh incompatibility, red cell membrane defects like spherocytosis, or overwhelming sepsis. These infants require immediate evaluation, including direct antiglobulin testing, complete blood count with smear, and often sepsis workup. Blood group incompatibility deserves special attention. ABO incompatibility affects 15% of pregnancies, but causes significant jaundice in only 4%. The setup requires mother O with infant A or B, creating anti-A or anti-B antibodies that cross the placenta. Unlike Rh disease, firstborn infants can be affected since these antibodies exist naturally. Gestational age under 38 weeks exponentially increases risk through multiple mechanisms. Each week earlier doubles jaundice risk. A 35-weeker faces 4 times the risk of a term infant. Immature conjugation systems, delayed feeding, and increased bruising from difficult deliveries compound their vulnerability. Previous sibling phototherapy indicates genetic predisposition. UGT1A1 polymorphisms, G6PD deficiency, or hereditary spherocytosis often run in families. These infants need closer monitoring and lower treatment thresholds. East Asian ethnicity increases risk through higher prevalence of UGT1A1 variants, causing Gilbert syndrome. These infants show exaggerated physiologic jaundice, requiring phototherapy more frequently than other ethnic groups. Exclusive breastfeeding creates risk through multiple pathways. Delayed stooling increases enterohepatic circulation. Suboptimal intake concentrates bilirubin, and breast milk factors may inhibit conjugation. Supporting breastfeeding while monitoring closely prevents both dehydration and hyperbilirubinemia. Cephalohematomas and significant bruising provide ongoing bilirubin sources, as extravasated blood breaks down over days to weeks. Each milliliter of blood yields 17 milligrams of bilirubin. A moderate cephalohematoma adds substantial bilirubin load, requiring extended monitoring. Understanding the distinction between breastfeeding jaundice and breast milk jaundice prevents unnecessary formula supplementation while ensuring adequate intervention when needed. These entities share breastfeeding as a common factor, but differ fundamentally in mechanism and management. Breastfeeding jaundice, appearing early in the first week, results from inadequate intake rather than breast milk itself. The pathophysiology centers on dehydration and caloric deprivation. Insufficient milk transfer leads to weight loss exceeding 10%, hypernatremia, and decreased stooling. Without adequate stool output, bilirubin undergoes increased enterohepatic circulation. These infants appear dehydrated with dry mucous membranes, poor skin turgor, and lethargy. Management focuses on optimizing breastfeeding technique, ensuring 8 to 12 feeds daily, and supplementing with expressed breast milk or formula when weight loss becomes excessive. The jaundice resolves rapidly once intake improves. Breast milk jaundice emerges later, after day 7, in thriving, well-hydrated infants. The mechanism remains incompletely understood, but involves factors in mature breast milk that enhance intestinal bilirubin reabsorption or inhibit conjugation. Beta-glucuronidase activity in breast milk may deconjugate bilirubin, promoting reabsorption. These infants gain weight appropriately, stool regularly, and appear vigorous despite bilirubin levels occasionally reaching 20 milligrams per deciliter. The diagnostic challenge lies in excluding pathologic causes while supporting continued breastfeeding. A brief interruption of breastfeeding for 24 to 48 hours causes bilirubin to drop by 50%, confirming the diagnosis, though this approach risks undermining breastfeeding success. Most practitioners now continue breastfeeding while monitoring levels, using phototherapy when indicated. The condition resolves spontaneously by 12 weeks as infant metabolism matures. Physical examination for jaundice requires systematic assessment under optimal conditions, as visual detection forms our first screening tool despite its limitations. Proper technique maximizes accuracy, while recognizing when laboratory confirmation becomes essential. Proper lighting proves critical for accurate assessment. Natural light at a north-facing window provides ideal conditions, revealing subtle yellow tones that fluorescent lighting masks. When natural light isn't available, use bright white LED lighting. Never assess under phototherapy lights or yellow-tinted bulbs that distort color perception. The blanching technique standardizes assessment across different skin tones. Press firmly on the skin for 3 to 5 seconds, then quickly release. Observe the underlying color in that blanched spot before capillary refill restores normal skin tone. This technique works equally well in all ethnic backgrounds, revealing yellow discoloration that pigmentation might otherwise mask. Jaundice progresses cephalocaudally following Kramer's rule. The face and sclera yellow first at bilirubin levels of 5 milligrams per deciliter. As levels rise to 10 milligrams per deciliter, yellow extends to the chest and upper trunk. The abdomen and thigh show yellowing at 15 milligrams per deciliter, while hands and feet indicate levels exceeding 15 milligrams per deciliter. This progression helps estimate severity. A baby yellow only to the nipple line likely has levels below 10, while one yellow to the knees warrants immediate measurement. Beyond skin assessment, examine for signs suggesting pathologic causes. Hepatomegaly indicates possible biliary obstruction or hepatitis. Splenomegaly suggests hemolytic disease. Petechiae or bruising provide ongoing bilirubin sources. Lethargy, poor feeding, or high-pitched cry may indicate early bilirubin encephalopathy. The umbilical cord provides valuable information. Early cord separation or omphalitis increases infection risk, while cord blood staining suggests severe hemolysis. Clinical assessment of jaundice, while valuable for screening, has significant limitations that mandate laboratory confirmation whenever treatment decisions arise. Understanding these limitations prevents both missed pathologic jaundice and unnecessary interventions. Multiple factors affect visual accuracy beyond the obvious impact of skin pigmentation. The observer's experience dramatically influences detection. Seasoned nurses identify jaundice at lower levels than residents. Lighting conditions create variability, even with optimal technique. Infant hemoglobin levels affect skin color, with anemic babies appearing less yellow at equivalent bilirubin levels. Gestational age alters skin thickness and subcutaneous fat, changing how yellow appears. These variables combine to create substantial inter-observer variability. The critical limitation remains inability to detect dangerous levels reliably. Studies demonstrate that clinical assessment correlates poorly with serum levels above 12 milligrams per deciliter, precisely when accurate measurement becomes most critical. An infant appearing moderately jaundiced to the abdomen might have a level of 10 or 20 milligrams per deciliter. This uncertainty zone coincides with treatment thresholds, making visual assessment inadequate for management decisions. The image illustrates this perfectly, showing an obviously jaundiced infant where the exact level remains impossible to determine visually. Is this baby at 15 milligrams per deciliter, needing observation, or 22 milligrams per deciliter, requiring immediate phototherapy? Clinical assessment cannot distinguish these scenarios. Key rules emerge from these limitations. Never rely solely on visual assessment beyond initial screening. Measure bilirubin levels whenever jaundice appears before 24 hours, extends below the umbilicus, or persists beyond expected timeframes. Any infant being considered for phototherapy requires laboratory confirmation. Remember that pathologic jaundice often appears more intense than physiologic jaundice at similar levels due to concurrent illness affecting skin perfusion. When uncertainty exists, measure. A transcutaneous or serum bilirubin takes minutes, but prevents hours of worry or missed pathology. The spectrum of bilirubin neurotoxicity represents a progressive continuum from subtle dysfunction to devastating permanent injury. Understanding this progression enables early recognition and intervention before irreversible damage occurs. Bilirubin-induced neurologic dysfunction, or BIND, represents the earliest manifestation of neurotoxicity. These subtle changes often go unrecognized without careful assessment. Infants demonstrate mild lethargy, slightly decreased muscle tone, and less vigorous feeding. The key finding involves altered cry characteristics. The pitch increases subtly, though not yet reaching the piercing quality of advanced encephalopathy. Auditory brainstem responses show increased latencies, indicating early eighth nerve dysfunction. This stage remains completely reversible with prompt bilirubin reduction. Acute bilirubin encephalopathy marks the transition to clinically obvious neurotoxicity. The classic signs become unmistakable. Marked lethargy progressing to stupor, hypotonia alternating with hypertonicity, and the characteristic high-pitched cry that experienced nurses recognize immediately. Feeding becomes impossible as sucking reflexes disappear. The infant may develop fever without infection and seizures indicating cortical irritation. Without aggressive intervention within hours, permanent damage begins. The progression to chronic bilirubin encephalopathy, traditionally called Kernicterus, represents our failure to prevent permanent basal ganglia injury. The term Kernicterus, meaning yellow kernel, describes the characteristic staining of deep brain nuclei found at autopsy. Survivors face devastating sequelae: chorioethatoid cerebral palsy from basal ganglia damage, sensory neural hearing loss from cochlear nucleus injury, upward gaze palsy from oculomotor nucleus involvement, and intellectual disability of varying degrees. The arrow in the diagram emphasizes this continuum's critical message. Early stages remain reversible, but progression occurs rapidly, sometimes within hours. Once chronic changes develop, no treatment restores function. Acute bilirubin encephalopathy evolves through three distinct phases, each representing deeper brain penetration and more severe dysfunction. Recognizing these phases enables stage-appropriate intervention, while permanent damage can still be prevented. Phase 1 presents with lethargy, hypotonia, and poor feeding. The infant appears floppy with decreased resistance to passive movement. Parents often report their baby seems too good, sleeping excessively and requiring stimulation for feeds. The suck becomes weak and uncoordinated. These findings reflect bilirubin's initial effects on the reticular activating system and basal ganglia. At this stage, aggressive phototherapy or exchange transfusion can completely reverse symptoms within hours. Phase 2 marks escalation to medical emergency. Hypertonia develops, particularly in extensor muscle groups. The infant develops opisthotonus, arching backward with neck hyperextension. The cry transforms into the pathognomonic high-pitched, shrill sound that penetrates even busy NICUs. Fever appears without infectious cause, reflecting hypothalamic dysfunction. This phase represents the critical window where immediate exchange transfusion may prevent permanent injury, though some neurologic sequelae often persist. Phase 3 represents established encephalopathy with poor prognosis. The infant demonstrates pronounced retrocollis, persistent backward arching of the neck. Paralysis of upward gaze develops from oculomotor nucleus damage. Deep stupor progresses to coma. Seizures indicate extensive cortical involvement. At this stage, even aggressive treatment cannot prevent kernicterus, though exchange transfusion may improve survival. Risk factors multiply rather than add. Prematurity increases vulnerability through immature blood-brain barriers. Acidosis enhances bilirubin-albumin dissociation, increasing free bilirubin. Sepsis damages the blood-brain barrier while competing for albumin binding sites. Glucose 6-phosphate dehydrogenase deficiency causes ongoing hemolysis, maintaining toxic levels despite treatment. Each factor lowers the threshold for neurotoxicity. A septic 32-weeker may develop encephalopathy at levels a healthy term infant tolerates. Kernicterus spectrum disorder encompasses the permanent neurological sequelae resulting from bilirubin toxicity, with manifestations ranging from isolated hearing loss to devastating multi-system dysfunction. The diagram brilliantly illustrates how different features correlate with severity levels. The classic tetrad defines severe Kernicterus spectrum disorder. Choriothetoid cerebral palsy results from basal ganglia destruction, causing writhing involuntary movements that worsen with attempted voluntary motion. Sensorineural hearing loss, often profound, reflects cochlear nucleus damage. Paralysis of upward gaze indicates oculomotor nucleus involvement. Children cannot look up voluntarily, though vestibular reflexes remain intact. Dental enamel dysplasia creates characteristic green-stained teeth from bilirubin deposition during enamel formation. Neonatal hyperbilirubinemia severity correlates with outcome severity, as the spectrum shows. Mild cases may manifest only high-frequency hearing loss, detectable on auditory brainstem response testing. Moderate involvement adds motor planning difficulties and learning disabilities without frank cerebral palsy. The color gradient from green through yellow to red represents increasing severity, with animal silhouettes showing progressive motor dysfunction. Diagnosis requires combining history with characteristic findings. A documented history of severe neonatal hyperbilirubinemia, particularly with signs of acute encephalopathy, provides crucial context. However, many affected children lack complete newborn records, especially in international adoptions. The neurological examination reveals upper motor neuron signs with preserved cognition. These children often demonstrate normal intelligence trapped in dysfunctional motor systems. Neuroimaging shows bilateral globus pallidus hyperintensity on T2-weighted magnetic resonance imaging, though this finding may fade with age. Early identification enables optimal habilitation. While we cannot reverse basal ganglia damage, early intervention maximizes function. Physical therapy reduces contractures, speech therapy addresses dysarthria, and cochlear implants may benefit those with profound hearing loss. The tragedy remains that this condition is entirely preventable with appropriate neonatal monitoring and treatment. Gilbert syndrome represents the most common inherited cause of unconjugated hyperbilirubinemia, affecting 5 to 10% of the population. Understanding this benign condition prevents unnecessary testing and parental anxiety while ensuring we don't miss more serious disorders. The pathophysiology centers on partial deficiency of UDP glucuronosyl transferase 1A1, the enzyme responsible for bilirubin conjugation. Affected individuals maintain approximately 30% of normal enzyme activity, enough for baseline function but insufficient during times of stress. The genetic basis involves polymorphisms in the UGT1A1 promoter region, particularly the addition of extra TA repeats that reduce gene transcription. The clinical presentation follows a characteristic pattern. Baseline bilirubin levels hover between 2 and 4 milligrams per deciliter, composed almost entirely of unconjugated bilirubin. During stressors like fasting, dehydration, illness, or menstruation, levels may spike to 5 or 6 milligrams per deciliter, causing visible scleral icterus. The key diagnostic feature is the complete absence of hemolysis. Normal hemoglobin, normal reticulocyte count, and normal lactate dehydrogenase. The diagram illustrates how reduced UGT1A1 activity creates a bottleneck in the conjugation pathway. When bilirubin production remains normal but conjugation operates at 30% capacity, unconjugated bilirubin accumulates. This explains why fasting worsens jaundice. Decreased caloric intake reduces UGT1A1 expression further. The diagnosis often occurs incidentally during adolescence or young adulthood when routine laboratory work reveals mild hyperbilirubinemia. The fasting test, where bilirubin doubles after 24 hours of fasting, confirms the diagnosis but is rarely necessary. Treatment involves only reassurance. This condition carries no health consequences and requires no dietary restrictions. Understanding Gilbert syndrome helps recognize when mild unconjugated hyperbilirubinemia needs no further evaluation. Crigler-Najjar syndrome represents the severe end of the UGT1A1 deficiency spectrum, where near complete or total absence of enzyme activity creates life-threatening unconjugated hyperbilirubinemia. This rare disorder divides into two types based on enzyme activity and treatment response. Type 1, the severe form, results from complete absence of UGT1A1 activity. Various mutations create non-functional enzyme, leaving absolutely no conjugation capacity. Bilirubin levels skyrocket to 20 to 45 milligrams per deciliter in the first days of life, composed entirely of unconjugated bilirubin. Without immediate intervention, Kernicterus develops within weeks. These infants require emergent exchange transfusion, followed by intensive phototherapy for 10 to 12 hours daily throughout life. Even with optimal management, many develop neurological sequelae. Liver transplantation remains the only definitive cure, typically performed before permanent brain damage occurs. Type 2 represents partial enzyme deficiency with retention of less than 10% normal activity. The key distinguishing feature is phenobarbital responsiveness. This medication induces remaining enzyme activity, reducing bilirubin levels by 30 to 80%. Baseline bilirubin ranges from 7 to 20 milligrams per deciliter, low enough to prevent kernicterus in most cases, but requiring lifelong vigilance. During intercurrent illness or other stressors, levels may spike dangerously. The images demonstrate both the biochemical pathway disruption and the clinical manifestation. Notice how the enzyme deficiency creates complete blockade of the conjugation step, forcing all bilirubin to remain in its unconjugated neurotoxic form. The infant photo shows the intense jaundice these babies develop within hours of birth. Diagnosis requires excluding other causes of severe unconjugated hyperbilirubinemia, particularly hemolysis. The complete absence of conjugated bilirubin despite extreme elevations provides the critical clue. Genetic testing confirms the diagnosis and guides counseling, as this autosomal recessive condition carries 25% recurrence risk. Hemolytic jaundice results from accelerated red blood cell destruction, overwhelming the liver's conjugation capacity. Understanding the distinction between immune and non-immune hemolysis guides both immediate management and long-term prognosis. Immune hemolysis occurs when antibodies target red cell antigens. ABO incompatibility, our most common cause, affects infants with blood type A or B born to mothers with type O. Maternal anti-A and anti-B antibodies, naturally occurring IgG immunoglobulins, cross the placenta and bind fetal red cells. Unlike Rh disease, firstborns can be affected. The direct antiglobulin test turns positive, confirming antibody-coated cells. Hemolysis typically remains mild to moderate, though some infants require phototherapy or rarely exchange transfusion. Minor blood group antibodies create similar pathophysiology but occur less frequently. Anti-Kel, anti-Duffy, and anti-KID antibodies develop following maternal sensitization through previous transfusions or pregnancies. These often cause more severe hemolysis than ABO incompatibility. Rh disease, once our most feared cause, now rarely occurs due to ROGAM prophylaxis. When it does occur, the hemolysis can be profound, requiring intrauterine transfusions and immediate postnatal exchange. Non-immune hemolysis stems from intrinsic red cell abnormalities. Glucose 6-phosphate dehydrogenase deficiency, affecting millions worldwide, causes episodic hemolysis triggered by oxidative stress. Certain medications, infections, or even fava beans precipitate massive hemolysis. Hereditary spherocytosis creates chronically fragile red cells that rupture prematurely in the spleen. The blood smear shows characteristic spherocytes, small, round cells lacking central pallor. Other membrane defects, like leptocytosis, cause similar but milder hemolysis. Enzyme deficiencies beyond G6PD also cause hemolysis. Pyruvate kinase deficiency, the most common glycolytic defect, creates chronic hemolysis with characteristic echinocytes on blood smear. The key to diagnosis lies in systematic evaluation. Blood type testing, direct antiglobulin test, complete blood count with smear review, and when indicated, specific enzyme assays or osmotic fragility testing. The systematic evaluation of jaundice requires integrating multiple data points to determine both severity and etiology. The Butani nomogram serves as our roadmap, plotting our specific bilirubin levels against risk zones that predict need for treatment. Understanding this nomogram transforms jaundice management from guesswork to evidence-based practice. The graph plots bilirubin levels on the vertical axis against postnatal age in hours horizontally. 3 risk zones emerge: low risk, below the 40th percentile, intermediate risk, between 40th and 75th percentiles, and high risk, above the 75th percentile. An infant tracking along the high-risk zone requires closer monitoring and lower treatment thresholds than one in the low-risk zone. The nomogram's power lies in its dynamic nature. A bilirubin of 12 at 24 hours indicates much higher risk than the same level at 96 hours. History focuses on risk stratification. Gestational age profoundly impacts vulnerability. Each week of prematurity doubles Kernicterus risk. Family history reveals genetic predispositions like G6PD deficiency or spherocytosis. Feeding difficulties suggest inadequate intake, driving breastfeeding jaundice. The prenatal history uncovers maternal medications or infections affecting the infant. Physical examination extends beyond jaundice assessment. Hepatomegaly suggests cholestasis or metabolic disease. Signs of hemolysis include pallor from anemia or splenomegaly from extramedullary hematopoiesis. Cephalohematomas provide ongoing bilirubin sources as they resorb. Initial laboratory evaluation starts with total and direct bilirubin levels. The complete blood count reveals anemia, suggesting hemolysis or polycythemia, increasing bilirubin load. Blood typing with direct antiglobulin testing identifies immune hemolysis. Reticulocyte counts differentiate production problems from destruction. Additional tests follow clinical suspicion. G6PD levels in at-risk populations, albumin levels when considering exchange transfusion, and comprehensive metabolic panels for sick infants guide management. The hour-specific nomogram plot determines whether phototherapy starts immediately or monitoring continues. Hyperbilirubinemia classification creates actionable categories that guide treatment intensity based on gestational age and chronological age. These thresholds represent consensus guidelines balancing current icterus prevention against unnecessary treatment. The fundamental principle recognizes that younger gestational ages tolerate lower bilirubin levels before neurotoxicity occurs. A 35-week infant's immature blood-brain barrier and lower albumin binding capacity creates vulnerability at levels a term infant handles safely. This explains why treatment thresholds decrease with lower gestational age. We're not being overly cautious. We're responding to genuine physiologic differences. For infants 35 weeks or greater, significant hyperbilirubinemia starts at the 95th percentile on the nomogram. Severe hyperbilirubinemia requiring phototherapy occurs at total bilirubin levels, warranting treatment according to the American Academy of Pediatrics Guidelines. Extreme hyperbilirubinemia, demanding consideration of exchange transfusion, develops when levels exceed 25 milligrams per deciliter or reach exchange thresholds. The critical distinction for premature infants under 35 weeks involves different thresholds entirely. Significant hyperbilirubinemia occurs at levels 17 milligrams per deciliter or greater at 96 hours, and bund the 95th percentile track. These lower thresholds reflect their increased vulnerability. Exchange transfusion consideration begins at just 22 milligrams per deciliter in the smallest prematures. The classification system serves multiple purposes. It standardizes communication between providers. Saying an infant has severe hyperbilirubinemia immediately conveys need for phototherapy. It guides treatment algorithms, with each category triggering specific interventions. Most importantly, it ensures consistent care, preventing both undertreatment risking Kernicterus and overtreatment causing unnecessary parent-infant separation. Remember, these aren't arbitrary numbers, but carefully calibrated thresholds based on outcomes data. The gap between phototherapy and exchange thresholds provides a safety buffer, allowing phototherapy time to work before considering more invasive interventions. Understanding this classification system enables confident decision-making when that jaundiced baby arrives at 2 in the morning. Phototherapy revolutionized hyperbilirubinemia management by providing non-invasive treatment that converts toxic unconjugated bilirubin into excretable forms. Understanding the photochemical mechanisms optimizes our delivery and maximizes effectiveness. The mechanism centers on light absorption by bilirubin molecules in superficial capillages and interstitial spaces. When photons strike bilirubin's double bonds, 3 distinct reactions occur. Photoisomerization, accounting for 80% of clearance, rapidly converts the toxic ZZ bilirubin into water-soluble EZ and EE isomers. These configurational changes alter molecular shape, enabling excretion without conjugation. Structural isomerization creates lumilirubin. Through irreversible molecular rearrangement, photooxidation generates small, colorless breakdown products, though this contributes minimally to overall clearance. The diagram illustrates these pathways beautifully. Notice how each photochemical product bypasses the need for hepatic conjugation, crucial for infants with immature UGT1A1 activity. The reversible nature of photoisomerization explains rebound hyperbilirubinemia when phototherapy stops, while irreversible lumilirubin formation provides lasting bilirubin reduction. The light spectrum determines effectiveness. Blue-green light at wavelengths between 450 and 490 nanometers optimally penetrates skin while matching bilirubin's peak absorption. The spectral graph shows why standard white lights work poorly. Most energy falls outside therapeutic wavelengths. Modern LED units deliver narrow-spectrum blue light, maximizing therapeutic photons while minimizing heat production. Proper positioning ensures maximal skin exposure. Supine positioning alone exposes only 40% of surface area. Adding lateral positioning increases exposure, though frequent repositioning prevents pressure injuries. The safety profile remains excellent when following protocols. Eye protection prevents theoretical retinal damage, while monitoring prevents dehydration from insensible losses. Phototherapy's remarkable safety allows treatment in mothers' rooms, promoting bonding while reducing bilirubin. Phototherapy guidelines translate research into bedside practice, defining when to start, how intensively to treat, and methods to enhance effectiveness. These evidence-based protocols prevent both Kernicterus and unnecessary treatment. Intensive phototherapy delivers a radiance exceeding 30 microwatts per square centimeter per nanometer across maximal skin surface. This requires multiple phototherapy units or specialized intensive units, placing lights both above and below the infant. Standard phototherapy provides irradiance between 8 and 10 microwatts per square centimeter per nanometer, typically using a single overhead unit. The choice between intensive and standard depends on bilirubin level, proximity to exchange transfusion thresholds. The guidelines clearly state that treatment decisions must incorporate the AAP nomogram, considering gestational age, chronological age in hours, and risk factors. A 35-week infant at 96 hours with a bilirubin of 16 requires intensive phototherapy, while a term infant at the same age and level needs only standard therapy. The nomogram prevents cookbook medicine by individualizing treatment thresholds. Enhancement strategies optimize phototherapy effectiveness when bilirubin approaches dangerous levels. Multiple phototherapy units create an envelope of light, doubling or tripling irradiance. Some centers use reflective materials like aluminum foil beneath infants, though evidence remains limited. Removing diapers increases exposed surface area by 8%, seemingly minor, but potentially important near exchange thresholds. The blue-green spectrum proves most effective, with narrowband LED units outperforming older broad-spectrum lights. The key principle involves matching treatment intensity to Kernicterus risk. Intensive phototherapy reduces bilirubin by 30 to 40% within 24 hours, while standard phototherapy achieves 15 to 20% reductions. Starting intensive phototherapy early when levels approach exchange thresholds often prevents need for transfusion. Remember that effectiveness depends more on spectrum and irradiance than fancy equipment. Properly positioned standard units often outperform poorly positioned intensive units. Managing infants under phototherapy requires systematic monitoring and proactive intervention to prevent complications while ensuring treatment effectiveness. The images demonstrate both overhead and intensive phototherapy setups, requiring different management approaches. Bilirubin monitoring follows risk-based protocols. For infants with rapidly rising levels or those near exchange thresholds, check levels every 4 to 6 hours initially. Once declining steadily, spacing extends to every 12 to 24 hours. The first level after starting phototherapy often shows minimal decrease or even slight increase. This represents equilibration between tissue and serum bilirubin, not treatment failure. True effectiveness appears by 12 hours. Common issues arise predictably. Temperature instability occurs as phototherapy lights generate heat while increasing insensible water losses. Servo-controlled warmers help, but frequent temperature monitoring remains essential. Increased fluid requirements of 10 to 20% above baseline prevent dehydration. Monitor weights, urine output, and specific gravity. Loose stools develop from increased bilirubin excretion and altered intestinal transit. This actually helps by reducing enterohepatic circulation, but requires barrier cream to prevent breakdown. Eye protection demands vigilance. Patches must cover eyes completely without pressing on nasal passages. Check positioning every 3 hours and remove during feeding to assess for conjunctivitis. Corneal abrasions occur if patches slip, allowing light exposure while preventing blinking. Bronze baby syndrome creates gray-brown skin discoloration in infants with conjugated hyperbilirubinemia. Purely cosmetic, but alarming to parents. Essential care maintains infant well-being during treatment. Remove infants for all feedings, promoting bonding and assessing for dehydration. Turn every 2 to 3 hours, preventing pressure injuries while maximizing skin exposure. Document irradiance measurements every shift, ensuring therapeutic levels. Many units display irradiance continuously, but handheld meters verify accuracy. Parent education reduces anxiety. Explain that sleepiness is expected, skin color changes don't indicate worsening jaundice, and treatment duration typically spans 24 to 72 hours. When managing immune-mediated hemolysis in neonates, intravenous immunoglobulin represents a critical intervention that can prevent the need for exchange transfusion. The mechanism involves blocking reticuloendothelial destruction of antibody-coated red blood cells, effectively slowing the hemolytic process. For Rh disease and non-Rh isoimmunization, we administer IVIG at 0.5 to 1 gram per kilogram over 2 hours. The timing matters. When phototherapy fails to control the total serum bilirubin or exchange transfusion appears imminent, IVIG becomes our next line of defense. The effectiveness depends on blocking those Fc receptors before significant hemolysis occurs. ABO incompatibility presents unique challenges. While some centers use IVIG routinely, the evidence remains less definitive than for Rh disease. The key is recognizing which infants benefit most. Those with positive direct Coombs tests, rapidly rising bilirubin despite intensive phototherapy, and clinical signs of significant hemolysis. The dose remains the same, 0.5 to 1 gram per kilogram. Remember, IVIG works by competitive inhibition. We're essentially flooding the system with immunoglobulin to prevent antibody-mediated red cell destruction. This mechanism explains why timing is crucial. Administer too late, and hemolysis has already progressed beyond what IVIG can effectively control. Exchange transfusion remains our most aggressive intervention for severe hyperbilirubinemia, reserved for situations where phototherapy and pharmacologic interventions have failed. Understanding the precise indications prevents both unnecessary procedures and dangerous delays. The absolute indication is straightforward. Any neonate with bilirubin encephalopathy signs requires immediate exchange transfusion. These signs include lethargy, hypotonia, poor feeding, high-pitched cry, opisthotonus, or seizures. Don't wait for laboratory confirmation when clinical signs are present. For other situations, we follow specific thresholds. In infants 35 weeks gestation or greater, exchange transfusion is indicated when total serum bilirubin exceeds 25 milligrams per deciliter despite intensive phototherapy. This threshold decreases with prematurity, hemolysis, and other risk factors. The decision involves more than just numbers. Consider the rate of bilirubin rise. An increase exceeding 0.5 milligrams per deciliter per hour despite phototherapy signals inadequate control. Similarly, failure of intensive phototherapy to reduce bilirubin levels within 4 to 6 hours mandates reassessment. Exchange transfusion replaces approximately 85 to 90% of the infant's circulating red blood cell mass, removing both bilirubin and antibody-coated cells. The procedure carries risks including thrombocytopenia, hypocalcemia, and cardiovascular instability, making proper indication assessment critical. Managing hyperbilirubinemia in special populations requires adjusted thresholds and heightened vigilance. These infants face increased bilirubin neurotoxicity risk at lower levels than term healthy newborns. Premature infants present our greatest challenge. Lower thresholds apply universally. The more premature, the lower our intervention threshold. Beyond gestational age, consider albumin levels. Preterm infants often have hypoalbuminemia, reducing bilirubin binding capacity and increasing free bilirubin concentration. This explains their vulnerability to Kernicterus at lower total bilirubin levels. G6PD deficiency demands rapid recognition and aggressive management. These infants can experience severe hemolysis, often presenting after discharge when exposed to oxidative stressors. The hemolysis may be explosive. Bilirubin levels can rise precipitously, overwhelming phototherapy capacity. Lower thresholds for both phototherapy initiation and exchange transfusion apply. Screen high-risk populations and maintain heightened surveillance. Sick infants. Those with sepsis, acidosis, or hypoxia require individualized assessment. Illness disrupts the blood-brain barrier, increases bilirubin production, and impairs conjugation. Acidosis particularly concerns us, as it reduces albumin-binding affinity for bilirubin. These factors combine to increase neurotoxicity risk. Treatment thresholds drop proportionally to illness severity. Remember, these infants may show encephalopathy signs at bilirubin levels considered safe in healthy term newborns.